Hello, my name is Jonathan Benger and I'm a Professor of Emergency Care at the University of West of England and a consultant in emergency medicine in Bristol. I also work for the critical care team of the South Western Ambulance Service and I want to talk to you today about AIRWAYS-2, for which I'm the Chief Investigator. AIRWAYS-2 is a cluster randomised trial of the iGel versus tracheal intubation in out-of-hospital cardiac arrest. And we're interested in the first advanced airway management that paramedics use when they're attending out-of-hospital cardiac arrest in adult patients. We want to estimate differences in the primary outcome, which is good quality survival to hospital discharge. So survivors, but also survivors who survive in a good neurological state and can return to their previous lives and return home to their loved ones. We're also interested in a lot of secondary outcome measures. So differences in the way that ambulance services work, the way that paramedics look after patients who are in cardiac arrest, and differences in the way that patients are looked after in hospitals and the outcomes for those patients in the long term as well as in the short term. We're also interested in costs. In particular, we want to make sure that the treatments that we provide are cost effective for patients and that they're cost effective for the NHS. Clearly, just very small increases in survival and good quality survival would be a huge benefit and a huge cost benefit to society. So we're looking for small but important benefits in our patients. The trial design is a parallel two-group randomised study. We're using a cluster randomised design, which means that it's the paramedics who are randomised. And we've got a lot of paramedics to randomise in order to make this trial work. Because the paramedics are randomised in a cluster randomised design, the patients that they attend will be randomised too. And that's the very highest quality research that will answer this important question about the best technique to use for initial advanced airway management, iGel or tracheal intubation in patients who are in cardiac arrest. We're running this trial in 4 English ambulance services, which are representative of the whole of England. And we have the support of the College of Paramedics and a lot of acute hospitals too. More than 100 hospitals will be participating in this study. We're looking for paramedics who are employed by one of those 4 ambulance services. So that's South Western Ambulance, Yorkshire Ambulance, East Midlands and East of England. And we're looking for paramedics who see at least 2 cardiac arrests a year. We're also looking for around 1,300 paramedics across those 4 ambulance trusts, and we'll be starting recruitment in March and April in 2015 with a view to starting patient recruitment in June 2015. The patients we are interested in are adults. So they're 18 years, or we think they're 18 years at the time of the cardiac arrest, or older. They're in non-traumatic cardiac arrest. So they've had a collapse, but there's no sign that there's been trauma involved in that collapse. And obviously they have to be attended by one of the paramedics participating in AIRWAYS-2. And that paramedic needs to be the first or second paramedic to arrive on scene. Also, of course, we can only enrol patients who are resuscitated. So a resuscitation attempt has to take place. That may or may not be successful, but a patient can only be included in AIRWAYS-2 if an attempt is made by the ambulance service to either continue or commence resuscitation. For the exclusion criteria, there are very few patients, adult non-traumatic cardiac arrest patients, who can't be in our study. But if a patient is in prison, if a patient cannot open their mouth more than 2 centimetres, which makes airway management very difficult, if they've been previously in our study, or if a relative indicates that that patient has already expressed a wish not to be in our study, then they won't be included in our trial. We need a lot of patients. So we need at least 9,000 patients to be sure one way or the other whether tracheal intubation or the iGel is best. That's 4,500 patients in each of 2 groups. And that will detect a 2% difference in that important outcome of good quality survival. And if we can find that, it will be a real step forward for our patients and the future of airway management in cardiac arrest. One of the interventions we're looking at is tracheal intubation. That's placing a cuffed tube in the trachea and ventilating the patient with that tube. We need all the paramedics who are participating in the study to use an intubating bougie wherever possible, and we also need them to use end-tidal CO2, carbon dioxide monitoring, which should be quantitative, using waveforms and numbers wherever possible. But if that's not immediately available in any particular situation, then we should use colour change devices until the numbers, the quantitative CO2 becomes available. The other group will receive iGel. The iGel is a supraglottic airway device. It's a second generation device, and our previous work suggests it's the most suitable device for use in out-of-hospital cardiac arrest in England, and it's very widely used already. Patients in both groups will receive standard care according to an algorithm that we have designed and agreed with the 4 ambulance trusts. And apart from airway management, all of the things that we do for the patients will proceed exactly as normal. The care that they receive in all other respects will follow the resuscitation guidelines that are current at that time. And patients will receive the very best care from the ambulance service and also from the hospitals that are treating them, according to the very best care that we can offer at this time. Unfortunately, some patients won't survive, and they will also be managed in the same way that we manage any patient who's unfortunate enough to not survive a cardiac arrest today. Our main outcome will be the modified Rankin scale. The modified Rankin scale includes death, but it also includes survival and quality of survival, and it's been widely used in stroke studies and in cardiac arrest studies in the past. Our secondary outcomes are quite wide. We're interested in how well the initial device works and how well ventilation proceeds. We're interested in whether patients have any problems with the initial ventilation, in particular whether there's aspiration or regurgitation or problems with vomiting during the resuscitation. We're interested in whether that airway works and whether it continues to work all the way to the hospital, and what actually happens and how the paramedic manages that patient's airway. If one form of airway management proves very difficult, so a patient is unable to be intubated, for example, then they can move across to the other option, the iGel. Similarly, if the iGel, after 2 attempts, proves unsuccessful, then the paramedic may try tracheal intubation instead. This is an important part of the study which guarantees that the patient continues to get the best possible care, and that care is as safe as it possibly can be. Both of these techniques are already in use in English ambulance services, and we need to find out which of them is the best technique to use first, accepting that sometimes it will be most appropriate to use the opposite technique, the other technique, when the first one fails. We'll be collecting all sorts of additional data from hospitals, and also lots of cost data to understand the costs of the 2 different treatments, to make sure that the care that we deliver is as cost effective as possible. But this isn't about saving money, this is actually about saving lives. And the important thing here is to identify the most cost effective treatment that can do the most good for the most patients. For patients who survive beyond hospital discharge, we'll be looking in more detail at their longer term survival and their quality of life, and how they're getting on 3 and 6 months after the cardiac arrest, so we can get the most possible information about long-term survival and long-term benefits. As I've said, we are recruiting 4 ambulance trusts into this study and over 1,300 paramedics. That's a big undertaking, and we need a lot of help with that. We also need help from 100 hospitals or more to follow these patients up and ensure that we collect all the data we need to make sure that we get the right results. At the moment, we're in equipoise. We do not know which treatment is best. And it's only by working together, paramedics, hospitals, ambulance services, nurses, doctors, that we can get the answer to this important question. So you will hear a lot about this trial in ambulance services and in hospitals, and I hope you'll want to help us. AIRWAYS-2 has been carefully thought out. It's supported by the National Institute for Health Research, and it's based on previous research that we have completed successfully. We've tried to use a simple design that can be delivered in this complex and challenging situation, but we need to answer this important question as clearly as possible. It's essential that you help us to get the answers that we need so that we can really improve the care that we deliver to out-of-hospital cardiac arrest patients, both in England, in the United Kingdom and around the world in the years to come. This trial will change the future of resuscitation, and we need your help to deliver it. Thank you.